Hi everyone, it's Dr. Renée, back for my weekly blog. And this week we're going to talk about menopause, because every time I do it on BBC Radio London we get inundated with calls because people just don't know enough about it. And obviously I have patients all of the time wanting more information. So here we go. So what is menopause? Essentially it's when a woman starts to run out of eggs that are released from her ovaries every month. And as fewer and fewer eggs get released, she starts to lose her estrogen. And eventually she'll stop producing eggs completely, and her period will stop, and she won't have any estrogen left, and neither will she be able to get pregnant. So when does it happen? Anywhere between about 45 and 55, but of course there are people outside of that. The average age of menopause in the UK is 51. But you can actually be peri-menopausal, so starting to get the symptoms for about 10 years before, so a long time. And people consider it to be a normal part of ageing. I would question that, because we used to die at 50, and so I would say, have we created it because we're much healthier now? Medicine and technology has allowed us to live into our 90s, even 100, and we certainly didn't live for 50 years without estrogen before. Anyway, enough controversy. What are the symptoms of menopause? So there are so many I couldn't name them all. The most common ones that you will have heard of are hot flushes, where the woman is overcome with heat and wonders why everybody in the room isn't throwing off their clothes and opening the windows. She can get night sweats as well, where she's soaking the sheets, throwing off the duvet, and then 3 minutes later is cold, so that wakes her up as she scrabbles around trying to grab the duvet. So insomnia is another symptom. Joint pain, headaches, palpitations, depression and anxiety, mood swings, a mental fogginess, an inability to think or remember things, reduced sex drive or libido, headaches, dry skin, vaginal dryness, and then the things you can't see necessarily. Our bones start to thin, and this is why women over the age of 50 start to get osteoporotic, and many more women are osteoporotic than men. And then our skin and hair, so we lose 6% of our collagen, so our skin starts to thin and look dry, and our hair thins. Those are just some of the symptoms. They're charming, aren't they? I'm sure men wouldn't put up with this. So just thinking about these symptoms, what are the effects? Well, imagine vaginal dryness, so that you can no longer have sex with your husband or partner. And I've had women phone up the station about that they're young at heart, they love their partner, but they just can't have sex anymore because it's too painful. So it's damaging to relationships. It puts strain on. Vaginal dryness, which can be painful all of the time, sex or not. And then urine infections, which are also painful. Mood swings and depression can affect relationships, the ability to interact with people, getting out of the house. So dramatic effects on life generally. And then that mental fogginess and lack of concentration stops some women from working. I've spoken to Crown Court judges who can't think anymore. So massive effects on day-to-day life and living. And when you consider that the government now wants us to all work till we're 68, and it will probably be 88 by the time I'm 68, we need to be able to think, we need to be able to work, we need to be able to concentrate. So this is a major thing for the future if we want a workforce that's continuing to work until they're nearly 70. And then of course their bones. So those quietly crumbling bones can result in fractures, hip fractures for example, which can be fatal. So really important and devastating effects on life. So what are the first signs, and how will you know that you're in menopause? Well, quite often women come to me and they're having the symptoms, the hot flushes, the mental fogginess, the aches and pains all over. They might still be having their periods, or periods might have become, scattered around. They might become heavier, lighter, further apart, closer together. You can have symptoms without your periods changing, or both can come together, or the periods start changing first. But those are usually the telltale signs that something's happening. And this combined with age is, how we judge it. And talking of age, I said to you the average age in the UK was 51. It's very genetic, so you'll quite often follow your mum. So if your mum was 52 or 55, and your sisters, that's probably when you'll have your menopause, unless something interferes to alter that. And that's what happened to me. So I had radioactive iodine for my thyroid. I had 2 big lots, and I went into an early menopause, started getting symptoms around the age of 42, 43. So I've been on HRT, so I must declare my interest. I'm a little bit biased, but I've been on it for about 7 years because I muddled on for a bit. So how do we make the diagnosis of menopause? Well, it's what we call a clinical diagnosis. So by that, I mean you don't need any tests in the main. So you go into your GP, who takes a good history from you, and in the main they'll be able to say, yes, you're in menopause, let's talk about the different treatments available. The only change to that would be if you fall into certain categories. So if you're young, having a premature menopause, so if you're under 45, if you've got a sudden change in bleeding, so you're having bleeding after sex, bleeding between your periods, or you've started bleeding again after menopause, that would need investigating. So we might do some bloods and we might do an ultrasound. We might decide to examine you and look for things. So if we think you're at a risk of deep vein thrombosis, if you're at a risk of having osteoporosis, a risk of breast cancer, all of those things, we would examine you and try and work out what the best treatment plan is for you. If we think you have gynecological disease, we'd refer you to the gynecologists. So in the main it's clinical, but we may do certain examinations depending on your history. Again, completely individual to you, as always with medicine. So I would hope as a GP that first of all I would talk about the signs and symptoms and the early stages of menopause and what to expect. Then I would discuss the available treatments all the way through from nothing to over-the-counter, herbal, through to hormonal and the different types. I would describe the risks and benefits of all of those, assess you on your bone health, and I'd talk to you about the importance of cervical and breast screening, which all women should have anyway because it's safe and it protects us, we know that. And depending on your age, I'd have to talk to you about contraception as well. So there are lifestyle approaches. So do nothing apart from change bits and pieces in your life. So if you're having hot flushes, wear cotton clothes, keep your bedroom cool, try to avoid triggers like spicy food and wine, exercise, we know that's good, and reduce your stress. If you're having sleep problems, keep your bedroom nice and cool, go to bed at the same time every night, no stimulation before, no late night exercise, just general sleep hygiene. Have a very light duvet. And then mood and anxiety, reduce your stress if you can, exercise, and try and sort all those sleep things out that I've just talked about. So those are the lifestyle changes that people can make to try and help the symptoms of menopause. I get asked all of the time about herbal remedies. Now in the NICE guidelines for menopause, they're not recommended because they're not tested and we don't know how much you're getting in the different brands that you're buying. They're not regulated. Having said that, there is some evidence for black cohosh for hot flushes and for red clover for anxiety, certainly better than placebo. So there is a role in some cases for herbal remedies, but obviously NICE don't recommend them. So what about HRT? Well, HRT got lots of bad press when the first Million Women study was published around 2004. But we now know that the study was flawed and that it looked at women who were starting HRT in their 60s when they'd already started to get their heart disease and other disease. So all of the advice has been updated and we now have new studies and new research, and lots of this can be found on the British Menopause Society website and Menopause Matters, and I'll put those details in below. So certainly HRT for women under the age of 60, there are more benefits than risks. In fact, more women die in that age range not on HRT than on HRT. Notwithstanding that, there are some risks and lots of benefits, and I'm going to talk to you about the risks now. So there is a slightly increased risk of a deep vein thrombosis or stroke if you take HRT as a tablet. But if you take it through the skin, and I'll explain how later, there is no increased risk at all of stroke or deep vein thrombosis. In terms of heart disease, we now know that if you start HRT close to your menopause, so within a couple of years, it's probably cardioprotective, so it protects your heart. And there's certainly no increased risk of dying of heart disease in this age group, under the age of 60. It makes sense. If women develop their heart disease when they lose estrogen, if you replace it close to when they lose it, it makes sense that that benefit will continue. In terms of breast cancer, if you have estrogen alone, and I'll explain that later, there's no increased risk at all. If you have estrogen and progesterone, there's a slightly increased risk, but it is tiny. It's an extra 2 women per 1,000. And to put that in perspective, the increased risk of breast cancer is no greater than women on the combined contraceptive pill. In fact, you've got more chance of getting breast cancer if you're overweight than on HRT. So hopefully that puts that into perspective, which I think is the biggest worry. Then in terms of ovarian cancer, NICE didn't study this, but we think there's a tiny increased risk of ovarian cancer. It's an extra 1 woman in every 1,000. So it's tiny, but it is probably there. So what are the benefits of being on HRT? Well, NICE have already said that less women die on HRT under the age of 60. I would say it's about feeling human again, because that's what it did for me. And there are other benefits, obviously. You have a decreased fracture risk because your bones don't crumble as they do when you lose estrogen. So that's major. Apparently I've got the bones of a 21-year-old. I jest, of course. It helps you maintain muscle mass, so you don't lose that muscle. And if you're going through premature menopause, you really need to think about HRT for your bones, because otherwise you've got a much longer period without estrogen, so a much greater chance eventually of having osteoporosis and a fracture. So, how do you take HRT? Well, I think the first thing to know is that depending on your age will depend on how you're treated initially. So if you're under 50, you'll need to have a treatment package which still sees you having a monthly bleed. Then once you've done that for 2 years, you can switch on to one where you don't bleed anymore. If you're over 50, you need to bleed for a year before you switch. The safest route to have HRT, as I've said to you, is through the skin. It's called transdermally. And there are 2 ways of doing that. Either as a gel that you literally just rub into your thighs or your tummy once a day, or as a patch, which you change twice a week. Both are equally protective in terms of thinking about the DVT or stroke risk. The subtle differences, however, are that if you've still got a uterus, so you haven't had a hysterectomy, you need to protect the lining of the uterus because estrogen on its own builds it up. Now the way to do that is with progesterone. So if you're taking the gel, you can actually take a progesterone tablet called Utrogestan, which is a bioidentical progesterone, or you can have a Mirena coil, which is licensed to stay in for 7 years. And the benefit of the Mirena coil is you're just having estrogen through the skin, no progesterone, so you minimise the risk of breast cancer again. For people that don't want to mess around with gels or Mirena coils or tablets, you can have a patch that's got both the estrogen and the progesterone in it, and you just change it twice a week. If you don't have a uterus, you can just have a patch with estrogen in it, and again you've got all the benefits of that without any of those risks. So it's easy to put it through the skin, but some women don't like that. Some women don't want to mess around with gels or patches, they want a tablet, and that's equally fine. So the pills are quite simply a combination of the hormones, either the same hormones all the way throughout the month and then you don't bleed, or they go in sequence and you do bleed, and your doctor will just recommend the one that's right for you depending on where you are in your journey. And that's it as far as tablets are concerned. There's not much else to say. So what are the concerns about HRT? Well, the one I think I get more than anything is, will I put on weight? I've heard I'll put on weight. The answer is no. In fact, the answer is that when you go through menopause, you put on weight and you lay your weight down around your tummy in a different way. And when I say that to women, then they say, oh wow, yes, that's what's happening to me. We know actually that on HRT you probably have a reduced fat mass. You definitely develop higher insulin sensitivity, so you're at no high risk of developing type 2 diabetes. So that's an urban myth and it doesn't exist, so you don't have to worry about weight. And there are the other benefits as well. So there are other treatments for women who can't take HRT or don't want to. So women who can't take HRT are ones who may have already had breast cancer that's hormone sensitive, or they've had a stroke, or they're at really high risk of breast cancer or a deep vein thrombosis. So you have to think about those things. Women that have had a stroke or at high risk can have HRT through the skin because there is no increased risk. But other than that, there are some other things that we can use. So we have vaginal pessaries of oestrogen, and there's almost no absorption into the body. So if you use a vaginal pessary all year and initially use it every night for 2 weeks and then just one twice a week, it's equivalent to taking 1 tablet of HRT in a year. So the risk is really minimal. For women who are on HRT but it hasn't fixed their sex drive, we can use testosterone gel, but it's unlicensed, and so we have to refer you into gynecology, and then if they feel it's appropriate they'll start it and then we can carry it on. There are other treatments that are not HRT at all. So there's something called clonidine, which is a blood pressure tablet. That has been shown to work for hot flushes, but there isn't much evidence for it, but lots of women report it helps them. You can get side effects like a dry mouth, fluid retention, depression. Then there's gabapentin, which is a nerve pain relief. There hasn't been enough studies on this, but there is some evidence that it helps in symptoms, hot flushes, etc. But there needs to be more evidence for that. And then there's tibolone, which is a steroid which mimics the action of the sex hormones and can be an alternative to estrogen, but again still has some side effects and has to be thought about carefully. So the message today really is, I don't think HRT is the devil that it was painted to be, and I think getting past that and telling women the true benefits of it, and there are lots of benefits and there are some risks, can bring a lot of women out of misery back to their normal selves and help them live a nice, happy, healthy life without pain or depression or anxiety or mental fogginess. I'm biased because I'm on it, but I declared that at the start. I'm not sure it is a natural ageing process because women used to die at 50, but that's just my view, don't shoot me down. We can discuss it after. Through the skin is safest, for sure, and more natural. You don't get any nasty liver metabolites. And in women under 60, the benefits outweigh the risks. So the last thing is there a stop time? Women think that they have to stop at 5 years. They don't. NICE now say there is no set stop time. As long as women understand the risks versus the benefits, the decision needs to be a joint one with them and their doctor. And I've got women in their 80s still on HRT. They need regular checks, obviously, breast mammograms, cervical screens, everything that a normal woman would have, and maybe a little bit more vigilant as you get older. But there certainly isn't a set time as laid down in the guidelines. So talk to your GP, think about it, weigh up the risks, and let them help you make a decision. If you do want to come off it, you can wean off it slowly so that you get past any symptoms that might creep back in. Essentially, there have been so many myths generated around menopause over the years that it's time for us as GPs to really make sure that we are debunking those myths that are wrong and damaging. There is a brilliant summary of some of these myths and the answers to them to show why they're not true at menopausedoctor.co.uk, and I'm going to put a link to this really brilliant PDF that does just that at the end of this, so that if I've missed anything or you need a bigger explanation, it's there in a really sensible way. So have a look and come back next week, watch my video, ask me any questions that you want to, and suggest topics as always. And thank you for listening.